So I've pre-mixed the simulated allograft bone, and I've drawn back in the syringe. And I have about 2/10 of a cc of bone. And then incrementally, I'm in the premolar, place it. And you never exceed beyond the crustal bone. So when you're at this step, suction is off because you don't want the assistant to inadvertently. So we'll have 2x2s, 4x4s draping. And also readily handy is cotton tip applicators to get saliva and ooze. And then you can use the wood end of your cotton tip applicator. Surely check first to make sure there's no splinters. And then you condense it to the level of the bone. And I actually use the butt end of my dental mirror, which I don't have in this setup, as my condenser. People ask how much pressure to condense the bone, and even though I'm a surgeon, I remember how much pressure to gently condense dental amalgam. I would say that's the pressure. Every dentist understands that amount of pressure, that feel. And then collagen plugs come, this is cut in half, so you'll cut it maybe in a third. Pardon me fumbling here. And then you'll place it over the socket. And here's where your assistant comes in handy, because once it gets wet with tissue fluid and the saline, then it can slime. So now I placed 2 interrupted sutures in an X pattern, and I'm going to do that. And I will honestly tell you that it's easier to sew oral mucosa than the simulation gingiva. And make your pull so that you only have about 1 or 2 inches protruding so that you don't have a tail being contaminated. And here's where your assistant comes in handy as you are bringing your knots. They're holding that collagen plug in place. And it's almost like wrapping a Christmas present. When you're putting the bow on, you need that third hand to hold that in place. And then just a simple square knot with a third throw to secure it. And we're usually in the aesthetic zone for this exercise, whether it's premolar or incisor. And we are taught in dentistry to have the knots on the labial, but more often than not, the patient's going, no pun intended there, more often than not, the patient is going to be leaving with a transitional removable appliance, aka a flipper or an essay. And the last thing you want is the knot sticking out on the labial. So I either tie them on the palatal or rotate them after I tie and cut, and that way it's not showing through. So I'm just throwing 1 interrupted in there just to give you an idea, and I usually just do an X. On occasion, you may need a third one in the middle. The next thing I want to show you is how to use the socket repair membrane, which is geniusly designed for the clinical scenario where we have a labial dehiscence from a chronic broken down incisor, and it has a facial perillus, and underlying that is a lot of granulation tissue, inflammatory tissue that has caused erosion of the bone. So you hold it from the top down, kind of looks like an ice cream cone, and you deliberately make a crease. So it's almost like a 45-degree angle. And again, this is where you and your assistant are ready to go. The syringe is full, the 2x2s are ready, and the cotton tip applicators are ready. So once you place this membrane, you have to act fast to get the material in there, because once it gets wet, it will slump. So you have it ready, you place it in the socket, and now, sorry about that, you place it in the socket, and now you have a ramp. It's within the alveolus. You have a ramp with which to pack your bone against, sop up the excess, gently place it, condense, add more and more, and then you get to the point where you have it to the level of the crest, and you fold this over, gently tuck it underneath, the lingual gingiva, and then you place your sutures. Now there is a technique that's been published. You'll see it in a lot of YouTube videos or product demonstrations where you flip that over and tie the margins of the socket repair membrane to the gingiva. That is really good in the very, very best of hands. However, you run the risk when you're manipulating the tissue and tying the knot of pulling that out from inferior crestally. And once you've displaced it, you've lost the purpose of why you're protecting that and rebuilding that with that barrier. So I am not an advocate of that. So instead of having a lot of suture and flying around, you just need a short tail. And you tie a square knot. And you're just passively tying the knot. This is not under tension, and you do not need primary closure. This is just to facilitate the collagen plug holding the sutures holding in place so that those surface crystals can be saturated in the first 24 hours, then it granulates in. There are techniques where people will use membranes and and that's very fine. That's up to your preference, but that adds cost to you and that you pass on to the patient for something that, as I mentioned, this is the very basic socket graft preservation grafting technique. And I'm asked a lot on is this billable or anything. Of course it's billable, and there's actually a code, ADA accepted codes, D7953. It is standing the test of time. So that's the exercise that we're going to do, or for those of you who are comfortable and you just want to incorporate this in your practice and you say, oh, so that's how it's done. It's great stuff.